just going to power through our last two sections. So first of all, hematology. So just some basic overview of some physiology things. So in the fetus, the first site of the red cell formation is going to be in the yolk sac. At 8 weeks, it later moves to the liver, and by 5 months, the bone marrow takes over, and that's where all the red cell production takes place from there on. So the MCV in utero actually is really high. It's like 180, and at 12 weeks, and it decreases by the time they're born to about 108. So the retics are about 5%. And there's actually some nucleated RBCs which will be normal at first. After 4 months, you'll see that at 4 months of life, the retic sum will kind of go down to less than 2%, and those nucleated RBCs will be gone. So just some lab abnormalities and weird things you might notice in the smear in a newborn, just be aware of. They quiz you on that. So the EPO stimulates RBC production. It's made in the liver in the fetus, and then later after birth, it's made in the kidneys, where we're more familiar with the EPO coming from. In a newborn, the hemoglobin will be pretty high, like around 17 grams per deciliter, and that's because of relative hypoxemia in utero, so that's why they have more red cells. The hemoglobin will reach its lowest point at around 2 months, and that's going to be where you have your physiologic anemia of infancy. So your average hemoglobin will get to as low as 9 to 11. Now your fetal hemoglobin, that's going to be present in birth and makes up 70% of the hemoglobin, and then this decreases to less than 2% by the first year of life. In patients with hemoglobinopathies or thalassemia, sickle cell, these patients will actually have elevated levels of hemoglobin F for a while. And then your RBCs, they have a lifespan of about 120 days. Your spleen will remove the old ones, any older damaged ones, and the hemoglobin is metabolized, so that makes the unconjugated bilirubin as the byproduct, hence like the turnover cells causing jaundice. So iron in the blood after the RBCs is broken down is transported by a transferrin, because it's transferrin the iron, so that's how I remember that, and then it's stored as ferritin. Okay, so this is just what a normal blood smear looks like. So you have like the lithocytes, which is kind of like the shape of the red cells. And you can tell that that's how they should normally look without too much pallor, just a little bit of central pallor. And then that's how a normal neutrophil should look like with only about 3 or 4 lobar segments. And then we see here that these small little things that are smudgy, way smaller than any of the other cells, that's going to be your platelets. Okay, so going over anemia, remember our presentations will be pallor, decreased activity, sometimes we're going to have jaundice with it, and our workup is a CBC, some red cell indices, which we'll talk about more, a purple smear, and a retic count. So anytime we talk about anemia, the first thing I want to know about anemia to classify is the MCV, because if it's microcytic, normocytic, macrocytic, that's how I can narrow down that differential. So your microcytic is going to be less than 80 with your iron deficient thalassemia, hemoglobinopathies, and some anemia of chronic diseases. Your normocytic is going to be from mostly your hemolytic anemias and anemia of chronic disease. And your macrocytics will be from B12 folate deficiency and bone marrow failures. So other things you can look at is the red cell distribution with. So with iron deficiency anemia, your red cells come in many different shapes and sizes. Hence, you have a large distribution of the different sizes of those cells. Your mean corpuscular hemoglobin concentration, that's going to be like how much each cell, how much hemoglobin concentration each cell has, and that's going to be elevated in hereditary spherocytosis. Okay, so I'm going to divide my anemia parts into 2 parts. Our first part is not going to be making enough, and our second part is going to be destroying too many of. So not making enough of is going to fall under iron deficiency anemia, which is usually because of inadequate nutritional iron intake, but you can also see that there's chronic GI blood losses. So we commonly think about it if you have a kiddo who is taking like too much cow's milk or had early introduction of cow's milk. Alongside of that, you can also have malabsorption due to celiac diseases. In adolescent girls, we want to think about menstrual losses because they have very heavy periods, then they can have a significant iron deficiency anemia. So other chronic causes of GI blood loss, you you got a 2-year-old, so they have Meckel's diverticulum, that can cause GI losses, also H. pylori, ulcers, or inflammatory bowel disease. Worldwide, we don't think about it here, but worldwide, we can think about hookworm infections as one of the most common causes of chronic GI blood loss. Again, with our iron deficiency, we have a low MCV, a low mean corpuscular hemoglobin concentration, a low retic, and a low iron and ferritin and transferrin. Because our transferrin saturation is low, we have a high TIBC because we want to bind up. So we have more of an affinity to bind up iron. So our treatment is, of course, replacing the iron, but oral iron 3 to 6 mg per kg of elemental ferrous sulfate per day. And you want to watch for an increase in the reticulocytosis in the 1 to 2 weeks. That shows the response to the therapy. The AAP has a few recommendations for preventing iron deficiency, and those includes breast milk for until 5 to 6 months of life, and supplementation after 4 months. Iron-rich formula, not breastfed. Iron-rich cereal when you're first introducing foods to the infant, and no cow's milk in the first year, also because of the alcohol GI bleeding risk. And so this is a very classic peripheral smear for iron deficiency anemia. As you can tell, compared to our normal smear, we have a lot, the cells are much more hyperchromic, so you can see there's a very significant central pallor. And you can tell like the cells come in, they're not all nice and have that nice elliptocyte appearance. They all come in some random sizes and shapes. Okay, another cause of anemia from not making them is going to be thalassemias. And so these are inherited disorders from absent or decreased production of either the alpha or beta chains within hemoglobin. And your MCV is going to be very low, lower than iron deficiency. So iron deficiencies, our MCVs are probably in the 70s range. These can be low in as low as the 60s. So we have beta thal minor, which is heterozygous with just one allele, and this causes a mild anemia. We can have beta thal major, which when you're homozygous for both of the thalassemia mutations, and in this case, you make none of the beta globulin chain. So in this case, you can have bone marrow hyperplasia with frontal bossy and those chipmunk facies. Your hemoglobin electrophoresis will show almost all of just the fetal hemoglobin type. And these kids are transfusion dependent, and because they receive so many chronic transfusions over the course of their life, they might need chelation therapy because of iron overload. Your alpha thalassemias come in different types, and the more alleles you have, it's going to be more severe. So if you just have one allele, you're asymptomatic. If you have 2, you're asymptomatic, but maybe with like a mild anemia. And if you have 3 alleles or loci affected, you have moderate to severe hemolysis. When you have all 4 loci affected, that's called hydroxyl vitalis, and then that causes death in utero. And the way you find this is that they might notice that on newborn screen they have the hemoglobin Bart's type that's detected. Okay, so this is a smear for thalassemia, and what you want to look for is these target cells. Okay, moving on. Sideroblastic anemia. You had a diagnosis of these ring sideroblasts in the bone marrow, and these are basically iron-laden mitochondria hanging around the nuclei. Folate B12 deficiency, these are your megaloblastic anemias, which is caused by a delay in DNA synthesis and maturation of the cell. So you have the large RBCs, and you also have hypersegmented neutrophils as well. And folate deficiency, we want to think about lack of it in the diet, especially when they're having goat's milk. There's also increased metabolism during infancy, pregnancy, and lactation. Malabsorption and chronic diarrhea can cause that, as well as drug interactions like methotrexate or sulfonamide. Their treatment is to replace with folic acid, 1 to 5 mg daily. If B12 deficiency is also present, if you give the folate, you actually worsen those neurological symptoms with the B12 deficiency. So just something to be aware of is to also work out that B12 deficiency and treat that as well before giving folate. Your B12 deficiency is its most common cause is going to be lack of absorption. So remember, to absorb B12, you need the intrinsic factor from the stomach that's secreted from the parietal cells. And without that, you won't absorb B12 properly. So this is the pernicious anemia. There's a congenital type in patients less than 3 and a juvenile type in older children. And a juvenile type is caused by the autoimmune destruction of the parietal cells in the stomach. So other nutritional problems where you're not getting enough could be from short gut syndrome, a vegan diet, and mom who exclusively breastfeeds. And then the symptoms are irreversible neurological deficits. So they can have bilateral paresthesias, decreased proprioception or vibration. So these are things that you think about your dorsal column neurological signs. And then they can also have spastic ataxia, central scotoma, or dementia. You want to diagnose this with the presence of anti-intrinsic factor antibodies with low B12 and a high serum MMA. And here I have two smears. One of this one is showing, this one's taken from the bone marrow actually, because you can see that these red cells are still nucleated. And the stain here is this ring sideroblast, which is your iron-related mitochondria around the nuclei. And then here we have a slide showing your B12 or folate deficiency. And there's not much to really notice about the red cells themselves. It would be on a large side, but I would need an MCV to tell if they are in the megaloblastic category. But what's significant here is the neutrophil is hypersegmented. And so we usually just see 3 or 4 lobes, and here I'm counting 1, 2, 3, 4, 5, 6, 7, 8 different lobes. And so that's kind of how we tell from that smear. Okay, so still on the anemia we're not making enough blood cells. Aplastic anemia is when all cells are reduced with pancytopenia, and this is a stem cell problem. So a lot of cases are idiopathic, but some can be due to drugs like chloramphenicol, toxins like benzene, or radiation. Then we want to think about other infections like EBV, CMV, and parvovirus. So we look at the bone marrow failure syndromes as well, because aplastic anemia can also be seen as paroxysmal nocturnal hemoglobinuria. Bone marrow biopsy is how we're going to diagnose this with a hypocellular or acellular marrow, and we treat with immunosuppressive drugs or a bone marrow transplant. Fanconi anemia is an autosomal recessive disorder. It involves DNA repair, causing pancytopenia. And so these kiddos have short stature, absent or abnormal thumbs, abnormal radii, microcephaly, and capillary spots. 15% of these patients will have risk of developing AML, and a treatment for these is stem cell transplant. And then lastly, we have pure red cell aplasias with the aplastic or bone marrow disorders. And so these is just the anemia with reticulocytopenia. When it's a pure red cell aplasia, the other cell lines like the platelets and the white cells aren't affected. And so these can also be caused by parvo B19 infection. I think it cuts off a little bit, but also transient erythroblastosis of childhood, and then diamond black fan syndrome is the third one that's on there. I don't know why it cut off, but I should have it on another slide. So this is getting into the bone marrow biopsy that you can see. This is what it normally looks like. You can see how rich and cellular it is with all the different lines of cells, and this one's just like all fat there, so you can tell it's hypocellular. Okay, so this is the continuation of that slide with the pure red cell aplasia. So parvo B19, we talked about this already, so I'm not going to go into the whole presentation, but a treatment for this would be the IVIG. Transient erythroblastopenia of childhood is self-limited and seen in kids 1 to 3. You see like a normocytic anemia with a reticulocytopenia, and you treat with transfusions for symptomatic anemia. One of the congenital syndromes for hypoplastic anemia is going to be diamond black fan anemia. And so these kids have a macrocytosis or reticulocytopenia. Usually diagnosed as before 1 year of age, and they have congenital deformities like thumb abnormalities, like you see in this picture, short stature, glaucoma, renal anomalies, hypogonadism, a short or webbed neck, congenital heart disease, or intellectual disability. Okay, now we're finally getting into the other category of anemias where we're destroying too many of them, and there's too much turnover of cells, or cells are being lysed. And so our first one is hereditary spherocytosis. It's the most common congenital hemolytic anemia due to a defect in some of the cytoskeleton proteins, particularly spectrum and ankyrin. And we see it a lot in Northern European patients. So some kids have chronic hemolytic anemia, jaundice, reticulocytosis, and splenomegaly. Others have a compensated anemia and very few symptoms. So if you see increasing pallor in a patient, you want to think about aplastic crisis because these patients are at risk of that. And so parvo-V19 infection could be the culprit. So on labs, you might see the reticulocytosis, the high MCHC, or spherocytosis on smear. And then the way to really nail down this diagnosis definitively is a positive osmotic fragility test. So some patients will need splenectomy to prevent the spleen from eating up all the cells. But if you want to go down that route, you want to first give the pneumococcal, the H flu, and the meningococcal vaccines. Post splenectomy, patients will need penicillin prophylaxis as well. PNH is a paroxysmal nocturnal hemoglobinuria. It's a triad of hemolytic anemia, pancytopenia, and then arterial or venous thrombosis. It's diagnosed on flow cytometry for GPI-linked proteins, and its direct Coombs is actually normal, unlike some of the autoimmune type hemolytic anemias. So our stem cell transplant is going to be curative for this, but we really only offer to patients with refractory pancytopenia or life-threatening clots. G6PD deficiency, this is our X-linked condition that affects the enzyme glucose-6-phosphate dehydrogenase. So this enzyme is important because it helps against our oxidative stress in our body. And so it's not making enough glutathione, so that's why we're at risk for oxidative stress. Things that we're at risk for is when we have systemic infection, sulfur drugs, dapsone, primaquine, famotidine, because those all promote oxidative stress. We see it commonly in African Americans, and a diagnosis is to check the level of that enzyme. If you're in the middle of a hemolytic crisis, it's actually not a reliable test because what happens is in the hemolytic crisis, you lyse all the red cells that have that abnormal, that don't have the enzyme, so you're left with just the red cells that do have the enzyme, so it's going to be normal in a hemolytic crisis. So this one's hereditary spherocytosis. So you can see that there's no central pallor, so consistent with the elevated MCHC and also that these now have a very spherical appearance instead of lymphocyte appearance. Okay, sickle cell disease, autosomal recessive, and it's a point mutation leading from a change in glutamine to valine. So this can cause, when there's deoxygenation in the blood, this causes the hemoglobin S to polymerize and leads to the red cell sickling. They have a much shorter lifespan of the red cells. Remember, the normal span is like 120 days, and these just stick around for 15 to 50 days, so there's a lot more turnover. And then the sickling can lead to vaso-occlusion, and this leads to all those complications that we really want to know, and that's the pain crisis, acute chest syndrome, splenic sequestration, priapism, and strokes. The diagnosis is through newborn screening. At birth, infants will have high hemoglobin F, so that's why at first in infants you don't see them with any symptoms or any pain crisis. The symptoms can start around 6 months once you have less of the hemoglobin F. Okay, and so this smear is showing sickle cells, so we can see there's quite a few number here that have the change in appearance into the sickle. All right, complications of sickle cell, we can have autoinfarction of the spleen causing a functional asplenia, and then we're at risk of infection to the encapsulated organisms. Pain crisis is the most common complication. It's the most common reason for them to come to the hospital. 1/3 of patients will actually have dactylitis first as their pain crisis. Acute chest syndrome, this is an emergency in sickle cell, and it's diagnosed with a new pulmonary infiltrate plus fever. They'll also have chest pain, tachypnea, hypoxia. So you'll have the needle infiltrate and then one of these. It's caused by infection, infarction, atelectasis, or fat embolism, and it's a leading cause of death in the sickle cell patients in adolescents and adults. The management is going to be with respiratory support, hydration, antibiotics. You really want to cover with strep pneumo and the atypical bugs. And then there's splenic sequestration is when the sickle RBCs clog up the spleen and presents with splenomegaly, worsening anemia and thrombocytopenia. We manage it with IV hydration, red cell transfusions, and if it's recurrent or severe, you might have to remove that spleen. Okay, more complications of sickle cell. You can have aplastic crisis again from guess who? Parvo-B19. So you want to suspect when the anemia, when there's anemia with a low retic, because usually in your sickle cell patients and they're in pain crisis, you should have a high retic count. Strokes. So we see this more in kiddos who have one copy sickle, and the other one's going to be the beta with 0 from the thalassemia trait. And that's going to present weakness, changes in speech, headaches, or seizures. You need to do emergent exchange transfusions. Like, don't even wait to confirm the diagnosis with MRI. They need to get that exchange transfusion. In a history of stroke, they may require chronic transfusions to keep their hemoglobin S less than 30%, and that's going to prevent recurrence of the stroke. And then we see moya quite a bit, which is the collateral formation of vessels. Priapism is long, painful erections occurring in 10% of older boys and adolescents, and you manage with hydration, pain control, and transfusions. Sometimes you may need to actually get a needle and do aspiration of the corpora cavernosa and irrigate with epinephrine to alleviate the symptoms. All right, so the other hemoglobinopathies, sickle cell trait. These patients aren't symptomatic, really. They lead pretty normal lives and without any major complications like in sickle cell. In rare cases with extreme exertion or low oxygen saturation, like if they go climb a mountain, that might precipitate some symptoms, but those are pretty rare. They can have hyposphenuria, which is the lack of concentrating urine, or renal hydronecrosis with gross hematuria. Hemoglobin SC disease. So in this one, the patients are less anemic and they have less severe hemolysis. They might have microcytosis or target cells on their smear. The hemoglobin C disease is going to have a mild hemolytic anemia and splenomegaly, but they don't have any of those vaso-occlusive complications like the sickle cell disease. Your heterozygotes with the A and C have no symptoms, just lots of target cells on their smear. So overall, these other variants, less severe than the sickle cell disease is a big picture. Okay, getting down to our last few parts of anemias where we're destroying too many cells. Immune-mediated hemolytic anemias, these present with pallor, fatigue, jaundice, and dark urine. With our warm autoimmune hemolytic anemia, we want to think about new medications or any recent febrile illness when we're asking our history. Our direct Coombs test is going to help us with a diagnosis, and we're going to treat with steroids. If necessary, we can transfuse, but we want to transfuse with the most compatible RBCs, because remember, it's immune-mediated, and any antibodies are just going to worsen the picture. You can also have a cold agglutinin form of the disease, and this occurs with mycoplasma and EBV infections, and in this case, your Coombs is going to be negative, unlike that warm hemolytic anemia. And then lastly, this one we're very familiar with is isoimmune hemolytic disease of the newborn, where maternal antibodies cross the placenta and attack fetal RBC antigens. So you can have this due to ABO incompatibility or RH-mediated disease. Remember, if it's in a first pregnancy, it's probably going to be your ABO incompatibility, because mom has those pre-made antibodies against that A or B blood type. But your RH hemolytic disease, they have to acquire those antibodies from a prior pregnancy. So you're going to see those in the second or subsequent pregnancies. I also want you to be aware of every single blood cell type has a version of hemolytic of this isoimmune hemolytic disease in a newborn, and so we're going to see that. Same thing for neutropenia and thrombocytopenia as well. Okay, so we're finally done with red cell stuff. We're going to talk about our white cells and particularly neutropenia. So severe neutropenia is defined as an ANC less than 500, and patients are at risk of severe bacterial infections. If they have less severe neutropenia, then it's more going to be like skin infections, otitis media, stomatitis. If you are febrile or ill appearing, they need immediate broad spectrum antibiotics. So there's some other causes of neutropenia. Some chronic benign neutropenia has a persistently low ANC, anywhere from 200 to 1500, and you might have mild skin, mucosal membrane infections. We also have cyclic neutropenia, which occurs every like 21 plus or minus 3 days. So kind of like a monthly routine. There's a 3 to 5 day period of neutropenia where the ANC is less than 200. And so these cases are passed down autosomal dominant inheritance. Patients have fever, atlas, stomatitis, cervical lymphadenitis, rectal/vaginal ulcers, and infections can be severe or fatal in some cases. The severe congenital neutropenia is Cosman syndrome, and this one's autosomal recessive. The ANC is usually less than 200 with monocytosis and eosinophilia, and the children are predisposed to early death from bacterial infections. The Schwachman-Diamond syndrome is autosomal recessive. You want to think of this as like kind of like CF, but not really. So they have a lot of features like fatal-derived steatorrhea, pancreatic insufficiency, and recurrent infections. But what sets it apart from CF is that they have neutropenia and then these metaphyseal dysostoses. Your neonatal isoimmune neutropenia. So remember, this is just like an Rh-mediated disease thing, but now it's attacking the neutrophils. So you have these antibodies cross placenta attack fetal neutrophils. There's also an autoimmune neutropenia of infancy that occurs from 2 months to 3 years. This one causes a severe neutropenia, but only mild skin infections, and it's pretty self-limited. And then you can also have viruses and drugs that cause immune-related neutropenias. So antiviral antibodies can cross-react with neutrophils. And this is a very common cause, and there's really nothing that you need to do with it. Usually, like the cell lines will recover on their own time. And then there's also drug-induced culprits. So the ones that do this we see is anti-epileptics, antithyroids, NSAIDs, antihistamines, sulfa, and any of the synthetic penicillin medications. So lots of antibiotics I've seen have been culprits of that disease. So, and the treatment for that, of course, is stop dose medication. All right, so our last bloodline we're talking about is going to be the platelets. So our platelets last 7 to 10 days in the blood. If increased, the megakaryocytes in so if you see a large number of megakaryocytes in the bone marrow, then it's not a problem with platelet production. Many children will have sepsis with the thrombocytopenia, and that it's just the sepsis causing that. You also want to look for medications that can be causing thrombocytopenia as well. Neonates with congenital CMV can also have thrombocytopenia, and you want to look at the blood smear to find some other unexpected causes. So one of them is going to be pseudothrombocytopenia. So sometimes the platelets might actually be clumped on your smear, and that just doesn't mean there's actually a real problem in the patient, like a true thrombocytopenia. It's just that the platelets clump and the machine's reading it as slow. So ITP, this one's our immune-mediated destruction of the platelets following recent viral infection or immunization. There's petechiae, purpura, and it occurs spontaneously or after minor trauma. On a smear, there are going to be megathrombocytes, which are large platelets but not giant. So keep in mind, because that's how we kind of differentiate between these different syndromes is by how big or small the platelets appear. So these are going to be large platelets but not giant. A normal hemoglobin is going to differentiate this from TTP, HUS, or DIC. And if we want to get a bone marrow biopsy, if it's not like the typical ITP or a treatment, it's not going to seem to be working. So we treat whenever the platelets get as low as less than 10 to 20,000 or if there's any major bleeding. Treatments can be IVIG, steroids, anti-RH immunoglobulin, but you don't want to do transfusions again. Why? Because it's immune mediated, so if you just transfuse those platelets, they're going to be destroyed again. All right, so remember, there's also a version for platelets as well that comes from mom. So maternal autoimmune neonatal thrombocytopenia. This one's the most common cause of neonates. And again, you see this actually in moms who had ITP, and when they pass on their antibodies to the baby, then the baby becomes thrombocytopenia. So you can treat mom with IVIG in the third trimester, or you can treat baby with IVIG if the platelets are less than 20,000. Okay. So Wiskott-Aldrich, this one is a rare X-linked disorder, and it has severe thrombocytopenia. What sets it apart from the others is that you have small size platelets. Okay. And then A megakaryocytic thrombocytopenia with absent radii, that kind of just tells you everything in a name. So it's thrombocytopenia, and they have absent radii, but their thumbs are normal, and it's you see it with bleeding in the neonatal period. Okay, so these are some other problems with platelets. Now we're getting down into the quantitative issues with low platelets. Now it's about the qualitative problems. So that means these platelets don't have the right receptors, don't bind properly or aggregate, and so they don't function so well. So these are qualitative problems. First one we're talking about is Bernard-Soulier disease. This one's autosomal recessive with absent GP1B receptor. So these present with mild thrombocytopenia, and they have giant abnormally functioning platelets. It doesn't respond to ristocene, but aggregates when you give these other things. Glanzmann thrombasthenia is autosomal recessive with normal platelets, but there's poor aggregation in response to these things. There's an abnormality in the GP2B3A receptor, so it's unable to bind to fibrinogen. And so in the infant, you'll see some mucocutaneous bleeding. You can also have drug-induced platelet dysfunction, which we're all pretty familiar with because it's really common with aspirin. This is irreversible inactivation of COX enzyme, and NSAIDs reversibly inhibits the COX enzyme in the platelet function. All right, thrombocytosis. This is going to be our platelets. We got a lot of them, more than 500,000. A lot of causes are reactive due to acute or chronic infection, iron deficiency anemia, inflammatory disorders, or acute blood loss. In these cases, they're benign, and you really don't need to do anything for them. One syndrome to be aware of is essential thrombocythemia. And this one's a rare myeloproliferative disorder with platelets greater than 1 million. You can have thrombosis and bleeding because the thrombosis makes sense because you have a ton of platelets. The bleeding is because your platelet function is also abnormal, even though you're having a lot of them. So if you're not bleeding, you want to treat with aspirin to prevent thrombosis, and you can also give some platelet-lowering agents like hydrea or anagilide type. Anagilide, yeah. Okay, so these are the conditions that will predispose someone to bleed. I don't really want to get into all the nitty-gritty about how coagulation works, because that's like a med school thing, but just some basics to keep in mind is that hemostasis have two parts. One of them is the platelet part, where they have to come together and form a clot. The second part is the hemostasis, secondary hemostasis with the coagulation cascade forming the tight fibrin patch. Okay, so with the primary hemostatic defects, you'll just have superficial bleeding or bruising and some mucocutaneous bleeding. When you have a coagulation disorder or secondary hemostatic problem, then it's going to be more like deep tissue bleeding, like hematomas and hemarthrosis. So just bear this in mind when we think about our different syndromes, when we have our kid with hemophilia, and how that would present as opposed to someone with a platelet problem. So our 4 lab tests, we're all pretty familiar with this and ordered all the time. Our PT is our prothrombin type. It's measures the extrinsic and common pathways, so mostly factor 7, and it's going to be abnormal in liver disease, vitamin K deficiency, or warfarin use. Your activated partial thromboplastin time is your PTT or APTT, and it's measuring your intrinsic or common pathways, and it affects these factors plus von Willebrand factor as well. And if there's heparin use, then it's going to make it abnormal. We also look at the platelet time, and the bleeding time, this one isn't often done, but it's another thing you can do to measure bleeding disorder. So if they're both prolonged, you want to consider a factor deficiency affecting both intrinsic and extrinsic pathways. It can be also seen in liver disease, DIC is a big one, or severe vitamin K deficiency. If they're both normal, you want to consider a factor 13 deficiency. And remember, if you have a prolonged PTT, we want to consider doing the mixing study for correction. So the mixing study is when you mix it together, then it corrects. So that what happened was when you mixed, you replaced the clotting factor, and so then you know it's just the clotting factor that was deficient, that was the problem. If you mixed it and you still have a prolonged PTT, then you probably have an inhibitor present that's causing the clotting factor not to function properly. Okay, so now we're getting into our clotting factor disorders. Our first one, most common one, is the factor A deficiency or hemophilia A. This is, remember, this affects boys predominantly because it's an X-linked recessive disorder. We have an abnormal PTT. And then the classic presentation is that you have an infant who is going for circumcision, and after the procedure, they have excessive bleeding. Your disease will correlate with the amount of the factor VIII levels. So less than 1% of the normal levels will have severe disease, 1 to 5% will have moderate disease, etc. So we treat this with desmopressin and mild disease. And desmopressin actually stimulates von Willebrand factor to release extra factor VIII. And you can actually use this prophylactically if they need like a dental procedure or something to prevent them from bleeding. In more moderate to severe disease, you actually want to treat with recombinant factor VIII concentrate. But you got to be careful because they can develop a neutralizing inhibitor to the factor if you give that. Factor IX deficiency is also known as Christmas disease. It's also X-linked recessive, and this treatment is replacing with the recombinant factor IX. The von Willebrand disease, a deficiency or defect in von Willebrand factor, and it presents in girls with heavy menstrual bleeding. The bleeding time is prolonged, the PTT is normal or prolonged, and you treat again with DDAVP to kind of stimulate the von Willebrand factor production. All right, so these are just some random bleeding disorders. So factor 11, 12, 13, not really all that common or well tested. I would say with factor 12 deficiency, you have a very prolonged PTT, but there's no clinical bleeding. That's one of the things of note. DIC is the most common acquired consumptive coagulopathy, and it's always secondary to something else, usually from trauma, sepsis, cancer. What really happens is that endothelial cells get agitated, so it activates tissue factor and starts a whole cascade going. So there's increased clot formation and breakdown at the same time. So you have prolonged PT and PTT. You have decreased fibrinogen. Why? Because you're using it up in the clotting cascade. And then you have elevated D-dimer, which are your fibrin split products because of all that turnover with forming that fibrin plug. Your vitamin K deficiency results in decreased production in factors 2, 7, 9, 10, and protein C and S. And remember, protein C and S, they're not going to work to coagulate, they're actually working to anticoagulate. I remember that because CS, I think of coagulation stop, is how I remember that. So newborns, remember we give this vitamin K right after birth to reduce the risk of hemorrhagic disease. But other things that can cause deficiency, if you have liver disease, malabsorption, or if you have a breastfeeding mom that's on warfarin, it can also cause that too. So we give vitamin K, but if you have active bleeding, you probably want to consider giving FFP because that will work faster. Vitamin K will take like up to about 8 hours to work, so you want to give them something in the meantime if you're concerned you're actively bleeding. Lupus anticoagulants is common in kids with viral infection and resolves spontaneously. Causes includes the prolonged APTT, and it does not correct the mixing study. There's just a little bit on the hypercoagulable states. It's pretty uncommon in pediatrics. You usually have more venous than arterial thrombi. The most common cause of DVTs is going to be from the foreign body, like the central venous catheter in the bloodstream. Our deficiency in the anticoagulants can also cause our hypercoagulable states, and these can be from the protein C, S, or antithrombin. So we can think of acquired forms in nephrotic syndrome. Remember, we're spilling out the protein C and S, and that's why we have a hypercoagulable state. And then in factor V Leiden, there's a deficiency in protein C and S, and that's another case where we see lots of clots being formed. Okay. Let me just stop here, actually. I think it's a lot.